Thank you very much, Dr. Justin Ezekowitz, for joining us here today. It'd be great if you could introduce yourself to tell us about who you are and what you do.
Thanks, Dr. Sharma. Well, I'm a cardiologist in Edmonton, Alberta, and I work at the Mass-Kowski Alberta Heart Institute. And in addition, I'm the co-director of the Canadian Vigour Centre, and I wear a number of other hats, including the hat of which we'll be talking about today, is I'm the co-chair of the heart failure pathway for the Strategic Clinical Networks for Alberta Health Services.
Wonderful. And so why don't you tell us a little bit about the initiative that you are developing with regards to a provincial heart failure pathway to improve outcomes and treatments amongst patients with heart failure?
Sure. So this is a provincial initiative that we started just a number of years ago that built off two earlier initiatives that were really trying to tackle the issues around access and equitable care and a number of other topics that come up when we care for patients with heart failure. We started back in 2006 and did a province-wide initiative of bolstering up the heart function clinics and really harmonizing the care a little bit in the outpatient world. And then we kind of ramped that up in the inpatient world, led by my co-chair, Dr. Jonathan Howard out of Calgary, where we tried to optimize the care in hospital and a number of centers to really harmonize that around both things like order sets and pathways.
What were some of the unmet needs that this particular initiative was trying to address?
Well, the heart failure pathway really was trying to tackle a number of different features. One is that we recognized the care was being delivered really with a lot of variation across the province. Now in medicine, care variation is actually not a bad thing. Sometimes you need a lot of variation to tailor to an individual patient's risk or treatment strategy or preferences. But what we really wanted to do was improve the quality of care across all the domains, such as which medications were being used, how is follow-up planned, how is educational activities delivered, or what educational material did a patient get? And those are just a number of different things, but there's a grid of different things where there's a lot of variation in care, where we felt it could really be optimized and have a lot more people engaged in the care of a patient with heart failure. Because most people realize that most people with heart failure are quite sick, but they spend most of their life out of hospital, not in a hospital. So we need to enhance that transition between in-hospital to outpatient care, along with the tools that a patient may be able to use when they go home. To do that, it takes an entire workforce, not just one individual.
What were some of the challenges that you faced when trying to roll this out and trying to actually get this integrated and off the ground?
Great question, Abhinav. So one of the strategies we were able to leverage was we have a provincial health system, so that meant that we could harmonize a lot of the resources within inside a health system. But you also recognize that all politics is local, and that any single initiative, even if it's got everybody involved and best evidence, it's certainly hard to deliver on the ground. So we had a number of different strategies to tackle where we felt that we weren't winning the game and in terms of winning for patient care. And so some of the challenges are that we're very individualistic in how we think about medicine, and everybody has a preference on how they do things. And so there are some individual challenges that both Dr. Howard and I had to help facilitate so that people could come on board to kind of modern heart failure care and also kind of harmonize some of the outpatient care transition, which is not simple. We had difficulty engaging family physicians, and that's because it's a challenge in a primary care environment. And so we recognized that and did certainly include primary care physicians in the development of the pathway from the outset. We also engaged them all the way through, and they've been part of our heart failure steering committee all the way along to make sure that we don't miss that important angle. And the other parts that were really big challenges were simple, simple things such as it's going to be on paper or electronic, and how do we make this work in the electronic new Connect Care world that we're working with compared to the paper? And so you can imagine a grid of challenges that was really well managed by our strategic clinical network partners who were engineering the on-the-ground knowledge translation of this into the field. And without those individuals doing it, you really can't win because you aren't on the ground seeing the real issues that people are facing.
And so can you tell us a little bit more about some of the outcomes that you're hoping to achieve with this initiative? So let's say if you launch this and you get broad uptake and broad use, what are some of the outcomes that you hope to see?
The outcome-based ones are the ones we are typically familiar with, such as 30-day rehospitalization rates, representation to an ER, mortality rates that we're tracking over time. There's some quality of care metrics that we'd like to track better that are quite tricky to get at, such as medications, appropriate medication use, or dosing. Can be quite tricky to get at that, even with good quality data. And then the process ones are really about things such as, did a patient get the educational materials? Simple, yes or no. And so we track that on a live dashboard that HS has, where each individual hospital has a grid of different metrics that are being tracked, and they can see their own scores. And so that's the other part about this, is people can see how they're doing on each drill down to a ward or a hospital, and they can also see their neighbor. And as you were aware, Dr. Sharma, if you can see how your neighbor is doing, you really are sometimes incentivized to do a better job and to focus in on when you have challenges, or learn from them as well by asking them.
And so as we approach the tail end of our interview, I just wanted to ask if there are individuals in other provinces that are interested in finding out more about this care pathway and want to implement this in their own healthcare system or in their own hospital setting. Where can they go for more information?
Right, so we'd love for people to learn from our mistakes and also point out areas where we could have done things better, that there's always room for improvement. So we encourage people to either just reach out directly to myself or Dr. Howlett, and we can guide that process, because it is within the SDN of Alberta Health Services that this is being done. And we can help just facilitate getting more information to that individual. Because look, we're not perfect, and we're not doing it all perfectly. So we want people to take and adapt it and make it better.
And so just to wrap things up here, I know all of us are socially confined at the moment. So what are some things that you're doing to sort of relax and enjoy the current environment?
Well, I tend to like being outdoors a lot more. So I'm restructured my day to be a bit more outdoors, which is good for me and good for my health, I guess, as well. But also just being outdoors, and when I'm speaking to people like the Dr. Sharmas of the world and want to get a new project going, I'm trying to do that while I'm walking and while I'm a bit more mobile, which prevents me from being stagnant. And I think that's a big plus for me in this era.
That sounds wonderful. Well, thank you so much for your time.
Thank you, Abhinav.